I'm going to be talking about caring for women with epilepsy from my perspective. So the aims of the session are to increase your understanding about epilepsy, demonstrate the vulnerability of women with epilepsy, determine the effect of epilepsy on pregnancy and pregnancy on epilepsy, and define the contribution midwives can make to holistic care provision. So first of all, I just want to talk a bit about epilepsy itself. It is the most common pre-existing serious neurological disease in pregnancy, and it affects about 50 million people, can you believe it, worldwide, of all ages, more common in the very young and the elderly, but it can occur at any age. 75% of people with epilepsy live in low to middle income countries. In the UK, there's about 600,000 people with epilepsy who are treated with anti-epileptic drugs. There are 139,000 women of childbearing potential. That's between 15 and 50, and approximately 2,500 pregnancies per year. It's particularly troublesome. This is why I have a big problem with it, because potentially women could be embarking on pregnancy having been misdiagnosed. And the misdiagnosis rate in the UK is 20 to 31%. There's also an increased risk of teratogenicity associated with its treatment, anti-epileptic drugs. There is an increased incidence of poor adherence to anti-epileptic drugs in pregnancy, and in many parts of the world, people with epilepsy and their families suffer from stigma and discrimination. And I'm really sorry to say that that still occurs in this country too. It's important for midwives to understand the recurring features in maternal mortality reports. There were 14 deaths in the last triennium report during pregnancy and up to 42 days postnatally. 12 women died as a result of sudden unexpected death in epilepsy, and 2 women died in single rooms whilst in hospital care. There were a further 12 deaths from 6 weeks to 12 months postnatal. Poor seizure control, lack of preconception counselling, failure to refer for specialist support, poor adherence with anti-epileptic drugs, and women with active epilepsy and from marginalised groups were at particular risk. So this is just really to alert you to who you should be looking out for when you come across somebody with epilepsy. Now, epilepsy means you have a tendency to have epileptic seizures, and I know that sounds obvious, and if you've got a lot of knowledge about epilepsy, I don't want to insult you, but I just want to go over what epilepsy is. The signs and symptoms of the seizure are due to a transient, abnormal, excessive or synchronous neuronal activity in the brain. Now, there's a thing called the International League Against Epilepsy, and it's a well-renowned association of health professionals, and they are brilliant, I have to say, who define this condition as a disease of the brain. The diagnosis should be made by a specialist, preferably with expertise in epilepsy. And that's following at least 2 unprovoked seizures occurring at least 24 hours apart, or a reflex seizure caused by strobe lighting, for instance, or 1 unprovoked seizure or reflex seizure and a probability of further seizures occurring over the next 10 years. Or a diagnosis of an epilepsy syndrome. Even if a woman's epilepsy is considered resolved and she does not take anti-epileptic drugs, pregnancy may still pose a risk of seizure recurrence, so it's best to refer her for obstetric review. I've put a little icon on there for you to link for first aid, and there's lots of icons as we go through that I do hope that you'll come back to and have a look at in your own time. We're just going to actually talk a bit more about epilepsy here. The onset can be dramatic, emotional and life-changing. Therefore, it's unsurprising the diagnosis can be accompanied by a cycle of bereavement and post-traumatic stress. And recurrence of seizures during pregnancy can rekindle these emotions, as well as women losing their driving licence. Now, it's important a woman has a correct classification of epilepsy, because this guides investigations, treatment and prognosis and support, and it gives us an indication of what we're tackling in pregnancy. In some cases, there can be a combination of both focal and generalised epilepsy, but for the majority of people with epilepsy, they fit into either one of these groups. And most people, when they think about epilepsy, they only think about tonic-clonic seizures that used to be called grand mals. But actually that only occurs in 60% of people, and other people have all different sorts of seizures. Now you see on the left-hand column is primary generalized epilepsy, and this is more likely to be a genetic cause. There is no aura as such. However, some patients will describe frequent myoclonic jerks leading up to a tonic-clonic seizure, or a pre-ictal feeling, or they just might have change of mood. Myoclonic jerks can be particularly troublesome as they are sudden, they're short duration, and they're unexpected, and they can lead to dropping whatever you're holding, for instance, and that is why we tailor advice for people with these seizures when they're handling babies or hot liquids. Absences are more common in childhood, however they can be part of an epilepsy syndrome and continue into adulthood. They are usually brief, and the onlooker may not be aware they're occurring. Somebody might be having several hundred a day, and so it will affect their concentration. You might see an eyelid flutter or deviation of the eyes, or you might see a head nod, or you might see nothing at all. Tonic and atonic seizures are sudden and short and more common in our patients with learning disability. Patients with these types of seizures are at particular risk of head injury. Now, focal seizures on the other side, we've already said it's more likely to be a symptomatic cause. It may be known, so there may be a history, for instance, of head injury or stroke or meningitis or birth injury or anoxia, in which case it would be called symptomatic epilepsy. If we haven't identified the cause, specialists call this a cryptogenic epilepsy. So we think there's a focal cause, but we haven't identified what it is. Now, the characteristics of focal seizures will depend on which part of the brain they manifest from. And I put a little pictorial diagram as to the aura that some people can experience just from the different parts of the brain. For some patients, the seizure spread may be so quick that there is no aura, and this can present as a seizure with loss of awareness or a secondary generalized tonic-clonic seizure. So it may look like they've got a primary generalized epilepsy because the seizure spread has been so quick. However, having an aura can be protective, as it may allow enough time for the person to get into a safe position and call for help. This person particularly close to my heart, as are all my patients with epilepsy, but I came across this lady in Ethiopia who had actually fallen onto a fire, and the family had left her on the fire to rid her of the devil. And this lady actually helped me get over something that happened in my life. Now, the challenges in pregnancy. The reason why we treat epilepsy is to control seizures, reduce the risk of morbidity and mortality, to enable people to drive and optimize quality of life. It is also important to prevent epileptogenesis and suppress subclinical seizures. Epileptogenesis is a gradual process by which the brain develops epilepsy, can you believe? Other treatments for epilepsy include avoiding triggers for seizures. Now you think, well, that's fantastic, the person can avoid going on to medication. And there's also brain surgery, vagal nerve stimulation, and the ketogenic diet for children, and a modified Atkins diet for adults, which tends to go alongside antiepileptic drugs. So it isn't used by itself. Antiepileptic drugs cross the blood-brain barrier and the placental barrier. There are multiple types and they have multiple mechanisms. They can be neuroprotective and increase seizure threshold. And in the UK, 70% of people with epilepsy could be seizure-free with the right treatment. Now, we know what pregnancy is like. It's provocative for anybody. We've seen different ailments actually exacerbate during pregnancy. But the normal physiological and anatomical and pharmacokinetic changes associated with pregnancy can be provocative for seizure control. Now, the risks in pregnancy, however, are often overestimated, resulting in women remaining nulliparous, making misguided decisions about treatment, or opting for unjustified termination of pregnancy. And this particularly breaks my heart. Data from a large UK care study identified that pregnant women with epilepsy were twice as likely to stop anti-epileptic drugs as non-pregnant women with epilepsy. For pregnant women with epilepsy, those receiving anti-epileptic drugs less regularly before pregnancy, so i.e. not collecting their prescriptions, were more likely to stop receiving anti-epileptic drugs in pregnancy. And this goes, we have a big problem with adherence with medication with people with epilepsy. And it's not surprising in many ways because of the adverse effects that can occur as a result of taking them. Now, for vulnerability of women with epilepsy, seizures are usually unpredictable, they can be dangerous and life-threatening. Data indicate that there is an increased risk of seizure deterioration in pregnancy in women with focal epilepsy and women taking more than one anti-epileptic drug. Women with epilepsy have an increased risk of medical and psychiatric comorbidities. Epilepsy and anti-epileptic drugs, unfortunately, can have a negative impact on quality of life. Education, employment, driving, independence, sexuality, actually going out hunting for the opposite sex, fertility, contraception, bone health, pregnancy, breastfeeding, and ability to parent safely. And unfortunately, in this country, like many countries, the services for women with epilepsy and other people with epilepsy is fragmented. I've put a couple of links on here so that you can access these to see what is available for women with epilepsy who are taking certain drugs, and different news that is coming out that can be actually confusing for some women with epilepsy. You can look at that after the presentation. Now, I'd like you midwives and student midwives, or whoever's listening, to look beyond the diagnosis. Successful management of women with epilepsy requires a holistic approach and care tailored to meet individual women's needs. We can reassure most women with epilepsy about pregnancy, and it's important to speak positively rather than induce immense fear from possible complication. Seizure freedom for at least 9 months prior to conception is usually associated with 84 to 92% chance of women remaining seizure-free during pregnancy. For women with active epilepsy in the year prior to booking, we would recommend regular monitoring from the multi-professional team. The risk to a fetus of a single self-limiting seizure appears to be minimal. Any woman with a history of prolonged convulsive seizures should have an emergency medication plan in place to minimize the risk of status epilepticus. Women with epilepsy appear to be at increased risk of induction and possibly cesarean section, but epilepsy itself is not an indication for this, so it may be linked to lack of professional knowledge about epilepsy and fear that a woman's going to have seizures. There is inadequate evidence to determine if newborns of women with epilepsy taking anti-epileptic drugs have substantial increased risk of hemorrhage. Pregnancy probably causes increase in clearance and a decreased concentration of lamotrigine, carbamazepine, phenytoin, levetiracetam, and active oxcarbazepine metabolite. For these women, a combination of clinical and therapeutic drug monitoring may be recommended, but it may be something the woman doesn't want. She needs to make an informed choice about that. There appears to be a substantial increased risk of preterm contractions, labour and subsequent delivery in women with epilepsy who smoke. And don't forget, women who smoke do have an increased risk as well of major congenital malformations. Now, I've put this slide up so you can actually look at the statistics that have come from data from the UK Epilepsy and Pregnancy Register. But you need to be very careful how you present this information. And I prefer to empower women to look at the register. I want to say reassuringly, most babies are born at term without fetal abnormalities or adverse effects on cognitive development. We have a wealth of information as a result of the dedication of the expert team collating and interpreting prospective data from the UK Epilepsy and Pregnancy Register. The statistics arising from the register help specialists counsel women regarding the safety of their particular anti-epileptic drug regime. There is a wonderful question and answer resource on the website and a free contact number to talk to Irwin, who is an experienced epilepsy specialist nurse and midwife, and I consider a friend and colleague. Women with epilepsy who become pregnant, whether or not they're on treatment for epilepsy, are eligible to join the register, and this should be before any results of ultrasound scans are known. I've put a link on the bottom, as you can see, for the MHRA guidance for women taking sodium valproate. This includes professional and patient information. For some women, sodium valproate is the only drug that provides them with good quality seizure control. Without it, their life can be limited through the threat of uncontrolled seizures. In many cases, they would have to make an informed decision regarding conception. Therefore, midwives should be there to support their decision-making and sensitively use the guidance identified in the resource for professionals, and it does include a checklist. Now, for effective community support, treat the woman, not the condition, and provide vigilant maternal and fetal monitoring. You're the experts. I've put a link at the top, and this is to an obstetric resource pack that I updated with Beth Irwin from the UK Epilepsy Pregnancy Register. I designed the front sheet from my personal design tools to summarise a woman's epilepsy history. I'm now preparing a new professional tool and will update the RCM website when it is complete. The essence of good midwifery care is early booking and referral to the multi-professional team with the woman's consent. If the woman has a history of prolonged seizures, focal epilepsy, active epilepsy despite taking antiepileptic drugs, which means she's still having seizures despite the medication, or if she's taking more than one antiepileptic drug or sodium valproate, please ensure that you or the GP fax urgently to neurology and the consultant obstetrician for fetal and maternal medicine. There should be a shared management plan in the notes moulded to meet the individual woman's needs. There should be vigilant communication and recording of action to that communication and follow-up. If a woman has not been prescribed folic acid, preconception, then now's the time to start it. She'll need 5 milligrams once daily prescribed by the GP and continue to at least 12 weeks gestation. If a woman has uncontrolled vomiting and it's affecting absorption of her antiepileptic drugs, she should be assessed promptly, seen by her GP as to whether she needs an oral antiemetic or rehydration and parenteral antiemetics in hospital. If she is admitted, ensure she has a supply of her own meds because there'll be delay in getting them and there'll be a different generic brand which could affect her seizure control. Partners may never have seen a seizure, and we've already discussed why pregnancy can make women vulnerable for seizure recurrence. It is important the partner and family is aware of first aid and that you provide safety advice and tools for risk assessment to ensure a woman's well-being. These are available from the epilepsy support groups, and I've included the links for them at the end of this webinar. Smoking is likely to increase the risk of obstetric and fetal complications for women with epilepsy and be dangerous if a woman were to be smoking whilst having a seizure. Smoking cessation advice should be provided with the necessary tools for support. Women should be provided with information about the UK Epilepsy and Pregnancy Register, as I've already discussed, and encouraged to self-register in order to benefit from the excellent resource. There should be a vigorous follow-up of non-attendees to appointments. It may be the woman's health conditions deteriorated, or she can't get public transport, or she has memory problems associated with her epilepsy or anti-epileptic drugs. There should be a regular, non-judgmental inquiry about anti-epileptic drug adherence, especially if a woman is having seizures despite taking her medication. We are aware there is a higher incidence of mental illness in women with epilepsy, so it is important that as a standard inquiry at every contact in addition to maternal, fetal and physical health. Identify any safeguarding issues promptly, especially when women have seizures without warning. That will hopefully engage her and her family and her wider support network, and if necessary, action specialist services for women in vulnerable groups. Empowering participation in shared decision-making will enable women to feel in control of their pregnancy, but please do not forget to red flag a woman for urgent assessment if her medical condition is deteriorating. Please obtain a witness report of any seizure activity, as this helps determine the etiology. It makes sure, us as specialists, we're looking at something that's an epileptic seizure and not syncope, fainting, which women with epilepsy can do as well as people without epilepsy. If the woman is admitted, it's important she remembers and continues to take her own anti-epileptic drugs. So, for effective hospital support, it's important a woman feels central to all decision making and has ownership of her birth plan that she's actually composed herself. As with all labours, there should be vigilant maternal and fetal monitoring and appropriate escalation for any concerns. Reassure women with epilepsy that most will have a normal delivery and a healthy baby. The risk of seizures in labour is low, and guidelines recommend delivery in an obstetric unit. There should be one-to-one personalised care, and I personally encourage women to do their own safety and risk assessment, as you should be doing on the women. This includes taking their anti-epileptic drugs at prescribed times and avoiding placing women in a single room unattended. We advise avoiding pethidine in labour, as this is converted to norpethidine, which has the potential of lowering seizure threshold. If this type of analgesia is requested in early labour, diamorphine can be used as an alternative. Discourage hyperventilating, especially if the woman has a history of absent seizures, as it may provoke a seizure. There is no quality data for TENS, but other forms of pain relief are not contraindicated because of epilepsy. It's important to avoid triggers for seizures. So if you've got somebody with photosensitivity, and it is only 4 to 5% of the epilepsy population, and you've got a flashing bulb in your labour room, do turn it off, okay? Or place the woman in a different room. It's important to reduce the risk of vomiting, and if the woman has nausea, do recommend an antiemetic. A decision to use water during labour should include an individual assessment, and the woman should never be left alone or unattended. Always ensure she remains well hydrated and doesn't become overheated. Be proactive with seeking medical advice for signs of any infection, as it can be provocative for seizure control in anybody with epilepsy. And you might think, well, actually, if she has epilepsy, a woman should never be allowed in a bath or a pool. But you have to think that guidelines are guidelines, they're not rules, and women must have choices. And there's a complete different end of spectrum for women with epilepsy. Somebody might be having tonic-clonic seizures all the time, and you might have another lady with epilepsy who hasn't had a seizure for 15 years. So following birth, we advise all women taking anti-epileptic drugs to consent to intramuscular rather than oral vitamin K for their babies. And I always try and get the paediatricians, senior paediatricians, to examine babies who have been exposed to anti-epileptic drugs as soon after birth as possible. And this is really to reassure the women, because most of them are frightened that baby may have been harmed from the anti-epileptic drugs. I advise all parents to monitor their baby closely for excessive sedation, especially if baby's been exposed to a high dose of anti-epileptic drugs, when drug doses have been increased during pregnancy, and drugs prescribed in polytherapy, that means more than one anti-epileptic drug, and if a benzodiazepine, anything with am on the end, like clobazam, clonazepam, midazolam, diazepam, anything like that, because it can be accumulative and make the baby more and more sleepy. Remind women to continue to take their anti-epileptic drugs and do a risk assessment on the ward. Get the women to do it, so make sure they feel safe. Support women with their chosen method of feeding. Current evidence demonstrates no increased risk in cognitive issues in women with epilepsy who breastfeed. Breastfeed may ease withdrawal symptoms from anti-epileptic drugs. Seek advice from the paediatrician regarding babies who are preterm, jaundice, or when 2 or more anti-epileptic drugs are prescribed. Do not place women in single rooms. If you have the facility, it's wonderful if the partner is able to stay and support the woman. After all, they are the experts in the woman's epilepsy. Have the anti-epileptic drugs been increased in pregnancy? If so, following diuresis, the woman might experience signs of toxicity, and there needs to be prompt review of her medication, and a plan should be in place that should have been drawn up antenatally. With vigilant community support, there should be prompt detection of deteriorating physical or mental health. Try and avoid women with epilepsy having to travel for postnatal appointments. Safer to home visit. Be proactive with detecting infection, as this can be provocative for seizure control. Please reassure women that the risk of injury to an infant caused by maternal seizures is low. However, there is an increased risk of accidents in women who experience generalized tonic-clonic seizures, mild clonic jerks, focal seizures with loss of awareness. Sensible advice such as enjoying bath time together as a family and being vigilant with safety, especially around water, so when bathing and showering, and swimming, of course, is imperative. It's important to optimize family knowledge about first aid and provide information about safety devices. Sleep deprivation is associated with an increased risk of seizures. Therefore, provision of information about sleep health. There's some fantastic resources on the NHS Live Well site, so do look at that. And that will help reduce the risk. It's important to recommend either no or minimal alcohol and to provide ongoing support with smoking cessation. I've provided a detailed information link on a leaflet I regularly update for Epilepsy Action, and that's on caring for babies safely. It's babies and infants, so of course it includes advice like keeping medications out of reach of young children. Now, for preconception and future pregnancy advice, signpost women for timely preconception counselling. I've provided references for professional resources for the provision of accurate contraception advice, and I'd really like you to have a look at that from the Faculty of Family Planning and Sexual Health. When women are prescribed enzyme-inducing drugs such as carbamazepine, phenytoin, oxcarbazepine, and topiramate, which is a weak enzyme inducer, there is reduced efficacy of hormonal contraception, leading to an increased risk of unplanned pregnancy. And I'm sure all of you would have come across somebody who's already pregnant at their 6-week postnatal check. When lamotrigine is prescribed in conjunction with the combined oral contraceptive, this can lead to reduced lamotrigine serum levels, and this can possibly lead to seizure deterioration. So it's very important to consider that, if a woman wants to use that form of contraception. If there is risk of pregnancy, the woman should recommence folic acid 5 milligrams once daily. And if the woman is not under neurology or epilepsy specialist nursing care, of which there are many fantastic epilepsy specialist nurses in this country, please ask the GP to refer her for timely preconceptual care before future pregnancy. If the woman has generalized epilepsy, it may be appropriate for her and her family to be referred for genetic counselling. Now, here are some of just several hundred resources. I can't put them all on for women with epilepsy, and you could actually copy this page and then have that available so women can download it on their mobile phones. And it's wonderful watching them all come up, actually, because the pictures come up as well. And here's some references with some links that you can use too. Please use this webinar as an opportunity of reflecting on your knowledge of epilepsy and use the excellent professional and patient resources to increase your knowledge. This in turn will maximise joined-up support for women with epilepsy. I'm just waiting on publication on an article I've done for the British Journal of Midwifery on shared decision making, and an article for nursing, an article in Nursing in Practices Community Midwives supplement on optimising care for women with epilepsy. Please also look out for the pregnancy guidelines that should be published any day from the Royal College of Obstetricians and Gynecologists. And as you can see from the screen, my take-home message is midwives have a pivotal role in normalising the pregnancy of women with epilepsy, which can otherwise be lost in the medicalisation of their health condition. Thank you very much for joining me.